Hello everyone. In this session, I am going to discuss about withdrawal in critically ill children. So in critically ill children, we have four important things, which is sedation. Sedation and withdrawal are both interrelated. We have pain and delirium. So some of the symptoms are overlapping here. If you could see, a lot of sedation directly leads to later on to withdrawal, and prolonged sedation, criticality, and the stress of the illness leads to delirium. And pain, if inadequately controlled, can also has its own problems. So symptoms of a lot of symptoms are overlapping. So delirium is a lot of cognitive disorders. So they have disorders like disorientation, impaired speech, disorganized thinking, sleeplessness, tremor, hallucinations, pulling out lines. These things are seen in withdrawal also, whereas altered consciousness may be because of under sedation, over sedation, and delirium. Tense face, grimace may be common to both. So diagnosing, you can see that to actually make out which is the what are you dealing with depends upon the course of the illness, at what stage you are in, whether you are in excessively in the initial stage where you are sedating the child very well, or whether we are withdrawing the sedation. Then we can expect, or post sedation, post extubation, we can expect either delirium or withdrawal symptoms to be there. So we can see that symptoms can be overlapping. So we need to have proper ways to monitor, anticipate, and treat these conditions. So in this session, I'm going to limit the detailed discussion to withdrawal, although just a brief overview about pain. So pain in acute stages settings can be described as acute or prolonged. So acute pain can be either procedural, when you are having some procedure or surgical procedure or minor procedures, or it can be post-operative, or it can be a prolonged pain which may be associated with some diseases like sickle cell crisis, or prolonged pain, unfiltered, untreated malignancy or specific disease, for example, peritonitis. So pain assessment, briefly, pain assessment in verbal children who can communicate well can be done by these scores, which are the visual analog scale, numeric rating scale, Ausher scale, the Wong-Wecker faces pain scale. I'm not going to go into the details of these scales. So as they can report it, self-reporting is the gold standard of assessing pain. However, in younger children who cannot report the pain very well, you need some scales, you need some scores. So we have the faces, legs, activity, crying, consolability score, the comfort score, and the comfort behavioral scales. So we're looking at these scales. You can see that the comfort behavioral scale is a fair bit of a physiological parameters like alertness, calmness, agitation, respiratory response, physical movement. Flag scale is more better for assessment pain, whereas the comfort behavioral scale is rather slightly more suitable for assessing sedation. So both are these scores, the flag score and the comfort B scores, have some excellent validity and reliability in children. The comfort B scale actually was derived after removing two physiological parameters of heart rate and blood pressure from the comfort score. This was done because heart rate and blood pressure was a short-lasting response to pain and would tend to return to baseline in prolonged pain. As I told you, the flex score is more suitable for pain assessment, whereas the comfort B scale provides more information about sedation. Now coming to delirium briefly, what is delirium? Delirium is a disorder of cognition. It's a relatively acute onset within hours or days, fluctuating level of sensorium, which typically worsens in the evening. There is a disturbance of attention, there will be inattention or impaired awareness, along with altered cognition, which will not be better explained by another pre-existing condition, for example, mental retardation, dementia. And you, from the disease progress or the clinical context, you will have some idea that this disturbance that we are seeing is probably due to result of a medical condition or its ongoing management. To assess delirium, it's recommended. We have three recommended scales for assessing delirium. We'll not go into details of those scores. So these are the Cornell assessment of pediatric delirium score, the pediatric confusion assessment method tool, and younger, this is for more than 5-year-old kids. For less than 5-year-old kids, we have preschool confusion assessment method in ICU. So coming to the main topic, which is withdrawal in PICU. Withdrawal basically means it has been classified or defined better as iatrogenic withdrawal syndrome. It's been not intended, but it happens as a complication of the ongoing sedation. It usually happens when we are trying to wean the children off sedation, and we are trying to gradually reduce the sedative medications, and or we are trying to extubate, typically if the child is ventilated usually, so we are trying to extubate the child. It is primarily due to the development of tolerance and dependence. So tolerance is of various types: pharmacologic, physiologic. So this is due to actually pharmacologic tolerance, where you need a higher dose to maintain to get the same level of effect. And dependence develops when you, because you see this symptoms due to dependence, because you need ongoing drug in the body to suppress these symptoms. So it's a set of non-specific symptoms, because there is no one biochemical criteria for it. So it's a syndrome. So you need a set of features are there. For example, common features are autonomic activation dysfunction like tachypnea, tachycardia, hyperpyrexia, and diaphoresis. Some GI dysfunction is very common, like vomiting, diarrhea. CNS alteration is core features like agitation, jitteriness, seizures, tremors, hallucinations, and delirium. Delirium, as you see, is a part of withdrawal also. There's a lot of overlap is there in these symptoms. When we are using a lot of medication, it is very difficult to make out which of the medication, which of the drugs in the sedation that we were using has caused these symptoms. So we cannot always make out, but we can have some ideas to which was the main culprit. So we'll discuss these things later on. So what are the risk factors for developing withdrawal in ICU? So in this study in 2015 that looked at very nicely the risk factors associated with iatrogenic opioid and benzodiazepine withdrawal, and critically in children. So they studied a lot of factors. So they found that there are some patient level factors like age of the child. So younger the child, there is more chances of developing withdrawal. Criticality, duration of therapy, prolonged therapy, usually more than 5 days. Cumulative doses. So cumulative doses are basically different for different drugs, and not all can be quantified, but some studies have looked at what are the doses at which you can expect that will get withdrawal. There are some process level variables as to, in your unit, how frequently is sedation depth is being monitored, whether the children are being properly assessed for IWS, on what are the sedation weaning protocols being used, what are your drug choices, what is the mode of administration, so whether you are using all the drugs IV or you are using some oral drugs, whether we are using multiple agents or a single or one or two agents only. So all these variables directly relate to tolerance, and there are some system level variables which indirectly contribute to this condition, like whether this protocol, if this protocol is in place, whether there's adequate compliance with this protocol or not, whether interprofessional communication is there, what is the PICU bed availability, and whether the hospital-based sedative medication policies are there, whether they are limiting your choices, or whether they are forcing you to say similarly that they are forcing you to use only similar narrow range of medication for your ongoing sedations. So the onset of these symptoms usually start to happen once we start to reduce the medication. So onset may be delayed. Here it is important to understand that the onset may be delayed because of some metabolites, because some drugs like morphine has the morphine 3-glucuronides and morphine 6-glucuronides, and benzodiazepines also, they have endazepines. They make endazepines, which are the receptors they act at the benzodiazepine GABA receptor. So they can, due to these metabolites, even though we have come off the drugs as such, but these metabolites they may have delayed clearance, and you can get those ongoing symptoms or the ongoing manifestation of these problems. So the common culprits are opioids and benzodiazepines. So these are the most commonly used, most studied, and most reported drugs, the opioids and benzodiazepines, which lead to withdrawal. Although it is not that other drugs like ketamine, dexmedetomidine, propofol do not cause withdrawal. There are reports that these three drugs also cause withdrawal, but most of the clinical problems are being associated with opioids and benzodiazepines, and their withdrawal symptoms have been very specific, and there are specific choices are available, specific approaches needed to manage these problems. So as I discussed previously, the risk factors is the duration of sedation, usually more than 5 days, and the cumulative dose of the drugs. So here I'll just mention that one of the studies mentioned that looked at the kind of cumulative doses. So midazolam dose of more than 40 to 60 mg per kg, a fentanyl dose of around 1.5 mg per kg, a propofol dose of 4 mg per kg per hour. These are just rough numbers. So this could lead, if particularly if given for more than 3 to 5 days, could lead to sedation, withdrawal. So although this is initially, as I told you, that although it was initially noted with the opioids and benzodiazepines more, but it has been reported with other drugs like benzodiazepines, barbiturates, propofol, and also with the initial anesthetics like halofluorine and dexmedetomidine also, although it is one of the options when we use it for some of the symptoms of withdrawal. So use of multiple opioids and sedatives, age less than 6 years, and particularly if less than 6 months use more, these children are more prone for withdrawal. If you have a pre-existing cognitive impairment, for example encephalitis, meningoencephalitis, or post-encephalitis sequelae, say, or global developmental delay, these children may be more susceptible to developing withdrawal. As a critical illness involving the CNS, though this will all be predisposed to developing withdrawal syndromes. In this study in 2017, 1157 children with 35 PICUs were looked at. They also found that the risk factors were younger children, pre-existing cognitive functional impairment, higher sedative doses, longer exposure periods, and the multivariable analysis, younger age, pre-existing cognitive impairment, similar higher prevening mean daily opioid dose, longer duration, receipt of 3 or more prevening classes, and higher nursing workload and 1:1 nurse staffing. This can indirectly affect it, your development of withdrawal. So although opioids and benzodiazepines are the most commonly drugs associated with withdrawal, but IWS, it can happen with alpha-2 agonists like dexmedetomidine. So a lot of literature is there. The prolonged dexmedetomidine infusion can cause the managed withdrawal symptoms. The particular features associated with alpha-2 agonist withdrawal are rebound tachycardia, hypertension, agitation, tremors, sleeplessness, emesis, and diarrhea. Although it seems that these are seen in all, but tachycardia, hypertension, these are all attributable, seen more, have been attributed more to the direct alpha-2 agonist withdrawal. So the question comes, what can we do, as there is no one diagnostic feature of it? So we have to monitor for IWS. For monitoring of IWS, traditionally, a few years back, the only options available were the neonatal abstinence scores, the Finnegan's score, which was based most on the neonatal profiles. So later on, they started to develop, studies have been developing. So opioid benzodiazepine withdrawal scale came up earlier, which was a 21-item checklist which looked at 16 withdrawal specific symptoms. Also, there was one sedation withdrawal score, the SWS, which had 0 to 2 points for 12 items. But those two scores, the opioid benzodiazepine withdrawal scale and this SWS, both were they were tried to validate in the studies, but they did not have very good acceptable validation. So the two main scales which are now used are the withdrawal assessment tool 1 and the Sofia observation scale. So we will look at these two scales in a bit more detail. So the withdrawal assessment tool 1 is a 12-point numerical scale, and the scoring has been recommended to be done at 12 hours or less. Scores, if the total score, if you see it's more than 3, then you can say it is consistent with the presence of IWS. It, however, cannot differentiate between opioid or benzodiazepine withdrawal. It is highly sensitive and specific for overall scoring of IWS, with good inter-rater reliability. This is perhaps the most validated, well-validated score for delineating or diagnosing withdrawal. So this consists of these features like loose watery stool. There is 1 point for all of these. If it is present, you get 1 point. So it assigns a value of 0 for no or 1 for yes to the following factors: loose watery stools, vomiting, retching, gagging, temperature 37.8 or more, the state of sedation. The state of sedation is assessed by observing the patient for 2 minutes, whether it's asleep, awake, calm, distressed, presence of tremor, sweating, yawning, sneezing. So 0 to 9, total score is 0 to 12, and more than 3 is considered to be a positive score. You can say that child is having IWS. Just for mentioning here, I've just mentioned the state behavioral scale because it is recommended in the WTA1 that you assess the sedation as per the SWS scale. So as per the SCCM 2022 guidelines for assessing pain, sedation, withdrawal in children, the recommended scales for sedation assessment, sedation depth assessment is this state behavioral scale, and the other one is suggested score is Richmond agitation sedation scale, which is also very popular. So in this score, state behavioral scale, -3 is unresponsive, when you have no spontaneous efforts, no cough, no response to noxious stimuli, no movement at all. Whereas -2, -1 as comparing to less and less depth of sedation, to +0 with awake and calm, to +1 rest and difficult to calm, to +2 with agitated child. The second score, as we said, is the Sofia observation scale. It was validated as single center study. Its sensitivity specificity is quite good. It's good concurrent validity compared to the 12 point there in the WTA1. It's at 15 item scale. Here the changes in heart rate and respiratory rate, in addition to signs of autonomic dysfunction, are also there. So score of greater than equal to 4 is consistent with IWS here. Additional incorporation of movement disturbance and hallucination is there. So this is traditionally thought to be more specific for benzodiazepine withdrawal. It is assumed, it is thought, or it is been reported that the opioid withdrawal is more of a sympathetic response. You get more sympathetic response when opioid withdrawal is there, and when you have benzodiazepine withdrawal, the movement disturbance and hallucinations, inattention, sleep disturbances are more there. So the proponents of the Sofia observation withdrawal scale suggest that this score may be more sensitive in screening for benzodiazepine withdrawal as compared to the withdrawal assessment tool, which is said to be a very good score overall, but this cannot differentiate between the opioid and benzodiazepine withdrawal. This is the way it is scored: 0 to 16 years heart rate, breathing rate, baseline heart rate, autonomic tachycardia, tachypnea, fever, agitation, anxiety. You have the motor disturbances, then you have the symptoms like grimacing, sleeplessness, inconsolable crying. So just to summarize properly, this is the symptoms of components of the Sofia observation scale: anxiety, agitation, muscle tension. So these three symptoms in purple, motor disturbance, inconsolable crying, and hallucinations, are additional to the withdrawal assessment tool, and the proponents of this score believe that it's a better score for when you're trying to look at benzodiazepine withdrawal. This was another study which compared the three scores. So with how it is done, so the WTA1 score, the scoring is done 2 minutes before the treatment, 1 minute before the treatment. It is used to be done every 12 hourly. And Sofia observation withdrawal, you need 4 a.m., 2 p.m., 8 p.m. monitoring. In the event of suspicious IWS, you do 2 hours after you have suggested treatment if you have given something. And the opioid observation withdrawal scale, it is not been validated, so we'll leave that. It has more items. So we'll come to some management issues. So when this study looked at that, found that iatrogenic withdrawal syndrome frequently occurs when you don't have any algorithm for tapering of analgesic sedation. That is again comes again and again. And if you do not have any algorithm for how you are going to taper your medication, then you can get more incidents. So they looked at mechanically ventilated patients, newborn to 18 years, who were on more than 5 days of opioids and benzodiazepines. They found that as per the WTA1 score, there was 95% prevalence of IWS. In this patient cohort, there was no tapering protocol used. They looked at another set of children where newborns to 18 years, mechanically ventilated children. So they found that before the pre-algorithmic tapering, before the introduction of algorithmic tapering of analgesic sedation, the IWS prevalence was 95%, versus after the introduction of algorithmic tapering of analgesic sedation, IWS incidence came down to 52.5%. So this was another whole soul. They looked at in a broad perspective the strategies for prevention and treatment of IWS from opioids and benzodiazepines in neonates, children and adults. Systematic review. We looked at a lot of components. The complex multifaceted care and single intervention therapeutic interventions targeting specific components of the IWS management like drug type, administration, tapering durations. They found that these interventions as a whole failed to impact the clinical outcomes like duration of ventilation, and the effect on the occurrence of IWS and drug exposure was inconsistent. And they found that some of the interventions which actually improved the outcomes were actually all complex and multifaceted. So identifying, so you could not have pinpoint to one set of say intervention which actually leads to improved or reduction of withdrawal. Although we'll look at some what are the established or the acceptable standard treatment that we can do for the management of withdrawal. So as it is, a withdrawal is happening because you are trying to withdraw some drugs, so it's a receptor level problem. So you need for opioid withdrawal, if you have been using opioid, we need some opioid replacement therapy. If you are using benzodiazepine, we need some benzodiazepine replacement, and alpha 2 agonist replacement also may be needed. So options can be, you can use the drugs, the replacement drugs in a subcutaneous form or the patch form. So it's a receptor based phenomenon. So the drug concentration, the child has developed tolerance to versus the child. When you start reducing the dose, there comes a gap between the actual concentration and the dependent concentration that leads to the symptoms of withdrawal. So what options are available? So for opioid replacement therapy, methadone has been studied a lot. So methadone introduction gradually, tapering doses can be used for gradual replacement of opioid doses. For oral benzodiazepines can be used if we have struggling with benzodiazepine withdrawal, like oral lorazepam may be used, clonidine may be used, and if we are using dexmedetomidine withdrawal, clonidine may be used. Then other options are for different situations like paregoric, chlorpromazine, transdermal clonidine patch, oral or transdermal clonidine, or subcutaneous fentanyl or transdermal fentanyl also is an option, although the effect may not be better. It's difficult to monitor the depth of analgesia and sometimes it can lead to reactions. Although these are the actual specific options are limited, as we can see. So the one thing we can do is, before, when we are sedating the child, you can try some IV plus oral combination if possible. You can, or when you are trying to reduce, you introduce these oral alternatives before you take the child completely off the sedation regimen. So the actual approach nowadays recommended is, before the development of the problem, we should try to prevent or delay. That is the new approach of managing this withdrawal syndromes as a whole. So this was a simulation based study that took one cohort and looked at the reasons for developing withdrawal. So what happens when you have prolonged drug exposure? The prolonged drug exposure, you can see this line, this causes a development of drug dependence, and when weaning starts after say 14 days, the drug exposure now is lower than the exposure the child has become dependent. So when drug exposure is lower than the level of drug dependence, the difference between the two, that drives the risk of developing IWS. So they studied various combinations like fentanyl, midazolam, say ketamine, and morphine versus fentanyl. They found that, say for example, for fentanyl, they found that if you reduce very slowly, if you reduce the drug dose in very small quantity and slowly, then you get less withdrawal, versus if you say for morphine, the quantity of reduction is not important, the duration of reduction is more important. So these are just postulated ongoing studies which are looking at how to go about tapering or reducing the drugs to avoid withdrawal. So other things which are thought to have good effect is, although not strictly proven, but these have been various other studies. These are the studies which affect withdrawal as well as the other components like delirium also. So protocolized sedation analgesia is always better, because if we have a protocolized sedation analgesia rhythm, we can, in Josia algorithms, we can avoid overdosing, or we can use multiple drugs to avoid more doses being delivered of one individual drugs. You can have nurse-driven protocols when you can empower the nurses. Nurse-driven protocols have also been used where nurses have the authority to adjust the sedation doses as per their assessment at the bedside. Environmental optimization and avoiding stressors, like for example noises and not giving headphones, trying to promote sleep hygiene, avoiding stressors, cluster nursing, these things are closely associated with reduction in the overall incidence of both delirium and withdrawal. Early mobilization definitely helps in both delirium as well as withdrawal, and this ABCDEF bundle is there for if you are trying to reduce these problems. Here ABCDEF stands for assessment of pain, both spontaneous awakening and breathing trials. C is the choice of sedation analgesia, delirium monitoring and management, early mobility and exercise, and family engagement. So family engagement even in a critically ill child who's sedated, it is being studied that family engagement and talking to the child and everything, that can also affect your chances of developing, reduce your chances of developing delirium and withdrawal later on. The role of specific antagonists. So as we've seen the problem that there is a dependence at the receptor level. So whether you can introduce some antagonists like naloxone for opioids or flumazenil for benzodiazepine. These things are under study and do not have any strict, clear-cut proven role. They are under study and may come up later on. So thanks a lot everyone. This was all about withdrawal in children, and this was just an attempt to give an overview of this problem. Thank you.